allergist, Dr. David Stukus, is here to talk about food allergy myths and facts. This should be a fun that you're here with us today. This webinar is offered by Kids with Food Allergies as part of its educational outreach program. I'm Linda Mitchell, Senior Vice President at the Asthma and Allergy Foundation of America, or AFA. Kids with Food Allergies is a division of AFA. I have the privilege of being your moderator again this afternoon. Today's webinar is made possible through sponsorship from Sanofi. We rely on corporate partners like Sanofi for the financial support that enables us to develop educational programs for families. Guest presenters for all of our webinars are doing so as volunteers without compensation. They also prepare their presentations on their own based on clinical evidence when applicable. On behalf of AFA and KFA, I'm very grateful for Dr. Dave to donate his time to be here with us to discuss food allergy myths and facts. There's a lot of confusing information out there and even misinformation that we as parents have to navigate, so I'm glad that Dr. Dave is here to help us make sense of all of it. Next, please remember that this webinar is of a general nature only and is not medical advice or legal advice. You should consult your own physician for any medical advice you seek with regard to food allergies and any other medical conditions. If you have questions during the presentation, you can enter them on your questions box in the GoToWebinar platform that's on display on your device. And at the end of the session, Dr. Dave will answer some questions as time allows. We will likely not be able to answer all of your questions regarding myths and facts. Today's webinar is being recorded. You will receive a follow-up email in a few days, and it will have a link to the video as well as related resources that we will compile to supplement the webinar recording. After Dr. Dave's presentation, we will stop to give away some wonderful gifts from our corporate supporters, Hope Page and Libre Natural. The recipients of these gifts will be picked randomly from those still in attendance later in the webinar. And when we end the webinar, you will see a survey. Please share your impressions with us as we take your feedback very seriously to help improve the future direction of our webinar series. We also let the speakers know how well they did, and usually like to really hear what your thinking is about that. So finally, I'm going to go ahead and introduce Dr. Dave. Dr. David Stukus is an assistant professor of pediatrics in the section of allergy and immunology at Nationwide Children's Hospital in Columbus, Ohio. In addition to his interest in caring for families with food allergies and other allergic conditions, he also serves as the director of the complex asthma clinic there. In addition, Dr. Dave is a member of the Medical Scientific Council for the Asthma and Allergy Foundation of America. He serves as the chair of the Food Allergy and Anaphylaxis Subcommittee, and he also serves as a member of AFA's board of directors. Dr. Dave completed his residency at Nationwide Children's Hospital and fellowship at Cleveland Clinic. So thank you for joining us here today, Dr. Dave. You can go ahead and get started.
Oh, thank you so much. I'm so for the opportunity to be here, and thank you for all your support and the invitation. Thank you, everybody who's tuning in right now and who's listening later as well. It's, for those of you who know me through social media or through other interactions or have heard one of our webinars, you know that allergy myths are one of my, talking points. There's just so many sources of misinformation available out there, and what I want to do today is really go through just some of the more common ones that I hear in regards to food allergy. Before we do that, we have our poll results. So it looks like there's an even distribution regarding the age of children with food allergies from our listeners right now. And our next poll shows that most people have one child with food allergy, but there's about 20% have more than one as well. And then in regards to how they were diagnosed, looks like the majority of them, vast majority, had both a blood and a skin test. So we're going to cover both of those today. Okay. So Mel, if you can turn things over to me, we'll see if I can get things to drive here. So while we wait to looks like I don't have the slides here. So we'll work on getting the slides, but I have no disclosures that are relevant to today's talk. As Linda mentioned, I'm happy to volunteer my time to be here and talk to you all today. So now let's see if we can get those slides back up, perhaps. There we go. Okay. So,
Dave, they're open
yeah.
on my screen. If you want to have them on your screen, you'll need to open the file on yours. So just let me know if you want me to display them for mine, and you can tell me when to advance, or you'll need to open them on your screen.
Okay. So I have to open up the file that you sent me?
Yes.
Okay. Well, you know what? I'll just have you advance if that's okay.
Okay, that's fine.
We'll figure it out. Okay, so next slide, please. Sorry about that, everybody. So if you're interested, you can follow me on Twitter. I'm at AllergyKidsDoc, and hopefully most of you know at KFA Tweets for kids with food allergies, and then our parent organization, AFA, the Asthma and Allergy Foundation of America. Next slide, please. So the objectives, really, we're going to focus on a few. I could spend 4 hours talking about these things, but Linda only gave me 1 hour, so I guess we all get to miss out on that. But what we're going to talk about really is blood testing for food allergies, egg allergy and vaccinations, skin prick testing in young children and infants, shellfish allergy and radiocontrast media, and then we're going to finish up talking about anaphylaxis. Next slide. So but before we begin, let's tell a little story, and this is a true story. Next slide, please. That I saw of a 16-year-old boy who had no prior history of food allergies, and one day at school he developed a rash on his face. This happened shortly after lunch, and that day he ate a fish sandwich, had some milk, some fruit, and cookies. The rash really wasn't itchy or raised, and he didn't even actually know he had the rash until his sister, who goes to school, pointed it out. The next day he went to his doctor. The rash was still there. He was given some prednisone, which is a steroid to treat it, and then the care doctor said, you know what, I think this might be a fish allergy because that's what you ate that day. So they ordered this test called a childhood allergy profile. And next slide, please. And this is what came back. And go ahead and advance one time. So they were worried about fish allergy, but as you can see, cod was the only fish actually tested, and instead you got all these different results for all these other foods, including corn, peanut, shrimp, soybean, walnut, things like that. Next slide. Well, what happened was the results were actually sent to the school just in that format, and the school personnel, including the school nurse, interpreted the results, and they said, wait a minute, this piece of paper says that this person is now allergic to seafood, corn, peanut, tree nuts, soy, and wheat. The problem is this boy had no history of any problems with any of these foods. He was eating them all regularly without any issues. And the school took all these foods away from him, and for some reason I still don't fully understand, he was only allowed to eat spicy chicken when he was at school. And this poor guy actually got in trouble because he was sneaking food because he was so hungry, and he served 2 detentions for this because he was eating food when he wasn't allowed to in the classroom. Next slide, please. I luckily got to see him within 2 weeks of having the blood testing performed, and spent time doing an extensive history. It revealed nothing that was suggestive for food allergies. I actually had a picture of the rash on Mom's phone, and oh, by the way, it wasn't even consistent with an allergic reaction. It looked more like a rash you commonly get with a viral infection. We did skin testing completely negative for all the foods, and wrote a letter back to the school saying, please let this boy eat. So next slide, please. I like to start with this story because this really highlights the importance of understanding exactly how we can and can't use allergy testing, and we're going to spend some time talking about blood testing in particular. So, myths. You know, I try to be a mythbuster as much as I can, and where does this come from? I've been fascinated by this for the last several years, and a lot of these are actually, you know, taught by medical experts. These were things that I was taught when I was a medical student or resident. They get perpetuated through time. Teacher teaches the trainee becomes the teacher, so on and so forth. Many of them have been refuted, but it's really hard to undo a wrong. So if you have a previously held belief, people hold on to that. And then there really is this, you know, decade-long effect. You have all these clinical guidelines that get published in prestige journals, but it takes a decade before they really permeate down into clinical practice. And the reason for that is, you know, primary care physicians especially are busy folks. They're seeing 40, if not more, patients a day. They get 10 minutes per patient. It's impossible to keep up with all the latest and greatest in research. And then in addition to that, we have public perception. So if you spend any amount of time on the internet, I know I do because I like to try to figure out what kind of information is out there and what, you know, you all are reading for yourselves, you get a lot of anecdotal reports, and that's 1 in a million syndrome. So people will shout from the mountaintops that, aha, I have this condition, and, you know, I did this treatment and I was cured, and therefore it must apply to everybody. And, you know, anybody can have a voice nowadays with the pervasive nature of the internet. Next slide, please. Again. So if you look at, you know, the internet especially, almost 3/4 of all internet users look online for health information, and the vast majority of those start with a simple search engine, and there's really no regulation whatsoever in regards to what information pops up at the top of the list or anywhere on the list. And you know, there's always perception of, you know, if it's on the internet, it must be true. But why do we worry about this? Well, this is just, if it's wrong information, especially at the physician's office and on our level, it can lead to the wrong diagnosis, unnecessary testing. You're going to have inappropriate treatment options, especially for things like antibiotic allergies, drug allergies. It's going to increase the cost. And then ultimately, it's just not going to lead to the best care possible, and that's not what we strive for as physicians and healthcare providers. Next slide. So one of the things we did here was, as part of a team, we wanted to investigate how much of a problem this is. So we actually did a survey last year where we asked 400 physicians, both in training and out of training, pediatrics and internal medicine physicians, about 9 common allergy myths. We got this published just this summer, actually, in the Annals of Allergy and Immunology. We asked about food allergy, pet allergy, drug allergy testing, things like that. Next slide. And what we found was a little bit alarming. Go ahead and hit it one more time. So what we found is, I'll draw your attention to the left side, of all the respondents, those that actually answered more than half of the questions correct were in the minority. Less than 10% of respondents could actually answer more than half. And as you can see, 12% couldn't answer any of them correctly. The vast majority could only answer a third of the questions. So there's some huge disconnect regarding evidence-based medicine and what's actually being done at a primary care or non-allergist level. Next slide, please. Now, we're going to spend a couple of slides talking about the important difference between allergy and intolerance. And, as an allergist, I'm extremely picky about my use of definitions. Next slide, please. And for one of them, for allergy, this, for all intents and purposes, an allergy is when your body forms an immune response to an allergen that results in reproducible symptoms. And for our purposes today, immediate within a few hours and with every exposure. So if we're talking about IgE, or immunoglobulin E mediated food allergy, you're typically going to develop hives, swelling, and progress to difficulty breathing, difficulty swallowing, vomiting. You can pass out from low blood pressure. You can have anaphylaxis. Next slide. But there are other types of allergy as well. There are more delayed types of allergy. So when it comes to foods, you certainly can have an immune response to a food that doesn't result in hives or immediate symptoms. And these are going to be more things like cow's milk protein-induced procticulitis, which typically presents in infants who are taking cow's milk formula, and they have some bright red blood on their stool. You switch them over to a different formula, everything improves, and then by 12 months of age, it magically disappears. And this can also include things like very severe refractory eczema or atopic dermatitis or food protein-induced enterocolitis syndrome, things like that. Next slide. Now, when it comes to intolerance, this does not involve the immune system, but there are certain people that develop symptoms when they eat foods. This is almost always going to be gastrointestinal. So you can have bloating or gasiness, heartburn, vomiting, constipation, diarrhea. These can be more chronic in nature. They can kind of come and go over time. They're definitely not reproducible with every ingestion, and it may be more quantity related, whereas opposed to if you have a true food allergy, you can't even eat small amounts of it because it's going to produce the same reactions. Next slide, please. So we actually just talked about that. Now, so let's move on to our first myth. So we're going to talk about blood work and serum-specific or blood-specific IgE testing for foods. So our first myth is blood work will tell us what your child is allergic to. Next slide. So let's talk about sensitization and allergy. This is sort of our last definition slide. Sensitization is merely a positive IgE test towards an allergen. It can be by skin prick testing, intradermal testing, or through blood work. So you have a positive test result. So what's an allergy? Well, we already talked about, so for the purposes of this, IgE, mediated hypersensitivity, is you have characteristic symptoms upon exposure, and you have a positive IgE test towards that. So the history is extremely important when you're interpreting these test results. Next slide. In regards to food allergies, there are 8 foods that account for the vast majority of all food allergies. This includes cow's milk, egg, soy, wheat, peanuts, tree nuts, fish, and shellfish. Go ahead and hit it again. And these reactions, as we talked about, are objective, immediate onset, reproducible with every exposure. Next slide. The best test to determine whether someone is allergic to a food is ingestion of that food. I'm going to repeat that one time because this is extremely important. The best test to determine whether someone is allergic to a food is ingestion of that food. What is the history? What happens when you eat that food? If you're eating a food and you're not having any symptoms, you are not allergic to that food. Blood testing and specific IgE testing is really best utilized to confirm a suspicious history. And then if you're going to test for other types of allergies or non-allergic conditions like intolerances, IgE testing is useless. This really is only going to be able to detect specific IgE towards allergens. Next slide. Now, in regards to blood testing, go ahead and go through till the end of the slide. Levels of IgE can be obtained through routine blood work. It's very convenient because you can test for multiple allergens at once if you want. There's also another myth, so here's a sub-myth for you, sub-myth number one. You don't have to stop at medications. Medications do not interfere with blood test results when looking at allergies. You don't have to stop antihistamines like you do for skin testing. And skin testing can be uncomfortable because it can cause some itching, especially in younger children. They may not tolerate it as well. But so that's why one reason to consider blood testing. And then they have these commercial panels widely available. Go ahead, next slide. Now you get these results that are reported in a range from basically 0 to 100. A lot of times they'll also report them as these arbitrary classes. So it'll say class 1, class 2, class 3. And then you get a big fat exclamation point with anything that's above 0.1. So this is the result, this is the report that comes back to the clinician who ordered the test or that you may see as a parent. And a lot of times people will focus on these classes that are completely made up and really meaningless. Next, go ahead and hit again. Now, in regards to food allergy guidelines, go ahead and advance to the end of the slide. There are guidelines that have been published regarding all the best evidence in regards to testing for food allergies. And I'd like to highlight this box because alone, using serum or blood-specific IgG tests are not diagnostic for food allergy. The test itself is meaningless without the clinical history being taken into account. Now, we also know that specific IgG tests have a very high rate of falsely positive results. These are not good screening tests. You can't just order the test just to go ahead and see what we find. You can't just order a bunch of food allergy testing to say, oh, you know what? Let's just make sure we're not missing anything here. It doesn't work that way. When they're misinterpreted, which often occurs because they're falsely elevated, it often leads to a misdiagnosis. You're removing food from the diet without any good reason for it, and then it results to meeting nutritional needs, going out of your way to avoid foods if they're not necessary, and things like that. Next slide. This is a great study. Go ahead and hit it one more time. This is a study that involves thousands and thousands of children and adults called the NHANES study. And what they did was part of the overall study was they actually measured specific IgE to milk, egg, peanut, and shrimp. And as you can see from the red bar, in young children 1 to 5 years of age, almost a third of them had detectable IgE to one of those. So a third of kids, based on blood testing alone, had specific IgE that was elevated to milk, egg, peanut, and shrimp. And about 15% of adults had that as well. But we know that clinical rates of allergy are much, much lower than that. They're only 2 to 8%. So in other words, if you rely on blood testing alone, and this is real-world stuff here that people are sampling, if you just blood test everybody, you're going to overdiagnose food allergy 20 to 30% of the time. So this is not a good screening test. Next slide. The values differ by foods in regards to the cutoff points. There's really only been established cutoff levels for a few select foods, which I'll show you on the next slide. And oh, by the way, the level does not equate to the severity of the reaction. So allergy testing in general, by skin prick or by blood testing, cannot tell you how severe your allergy is. It can only tell you how likely it is that you actually have an allergy. Next slide, please. Go ahead. There you go. So these are the foods that the cutoff points have really been established for. A couple of things to note. One is the numbers are very different for the different foods, and these are pretty much 95% or 90% confidence intervals that an allergy is present. They're not very sensitive. They're a little more specific. So again, not good screening tests. And the values above these numbers mean it's almost certain that you are allergic to those foods. Values less than these numbers doesn't necessarily say that you aren't allergic. The curve is sort of like it has like a little S shape to it, so the values change based upon as low as it gets. The other thing I want to highlight from this slide is if you call me up and said, hey Dave, guess what? I have a specific IgE level of X, Y, or Z to banana. What does it mean? I have no idea what it means because those levels have never been established for anything other than these foods. So I would have to ask what the history is, what happens when you actually eat banana, what are the symptoms, why was it tested in the first place, and then you can help decide whether or not that's clinically relevant. So that's a really important point to understand. Next slide. And then lastly, before we get off serum IgE testing, while we're talking about blood testing, let's talk about IgG antibodies. So some of you may be aware of other antibodies, such as IgG. There's also IgM, IgA. And there are practitioners out there and websites and other sources of information that will say, we should do IgG testing for foods because this is the more accurate way to diagnose food allergy or sensitivity or intolerance and things like that. Well, here's the problem. IgG is a memory antibody. IgG actually is a marker for tolerance. And we know from all these great food allergy desensitization trials and aeroallergen immunotherapy, people will get allergy shots for ragweed, dust mites, things like that. As your body becomes less allergic, the IgE goes down, IgG goes up. And then straight as a quote from the food allergy guidelines, IgG testing does not have clinical relevance. They're not validated. They lack sufficient quality control and should not be performed. So in case you encounter this, There's a reason why IgG testing really is useless in the evaluation of food allergy or sensitivity. Next slide. Okay, moving right along. So myth number 2, egg allergy and vaccinations. This is very timely given our influenza season that we're about to head into. So as a quick background, there are a few vaccines that are prepared using hen's egg embryos. They just use these to help produce the vaccines and enrich them. Measles, mumps, rubella, rabies, yellow fever, influenza are the most prominent ones. And this allows the opportunity for very, very trace amounts of egg protein to potentially be introduced in the vaccine. Next slide. Oh, by the way, reactions to vaccines do occur. There's actually a publication coming out in the Journal of Allergy and Clinical Immunology that literally demonstrates that it's 1 in a million. It's actually more than that. It's like 1 in 1.3 million episodes of anaphylaxis to vaccinations across the board. So allergic reactions are rare, but they do occur, and it's often to other ingredients. So there are things like gelatin, which is used as a binding agent to help make sure that the vaccine stays stable, neomycin to help preserve the vaccine, protect it from getting contaminated. These are agents that can be sensitizing and cause reactions as well. So I'm not here to say that allergic reactions to MMR influenza don't occur. They do. It just may be due to another component. Now, in regards to the measles, mumps, rubella vaccine, go ahead and go through this slide to the end. The first report was 50 years ago in the Journal of in JAMA, and this was the first report demonstrating the safety of the measles vaccine. 20 years later, in the New England Journal of Medicine, were definitive studies showing that MMR is very safe in people with egg allergy. I bring this up only because I still get referrals once every 3 to 6 months for patients with egg allergy that their physician will not give them an MMR vaccine. Next slide. If you looked at the Red Book is sort of our guide to infectious diseases and diagnosis and treatment and vaccinations as well. And this is straight from sort of the guideline-based book for that. Basically, you can read the slide for yourself, but it says that there's no need to worry about egg allergy prior to administration of the MMR vaccine. You don't have to skin test for it, and you can administer without any special precautions whatsoever. So there really is no debate about the MMR vaccine being contraindicated in egg allergy anymore. But I still hear this. Next slide. Now, in regards to influenza vaccine, up until recently, there was debate because we didn't know. What sparked the new interest was in 2009, some of you may remember, there was a pandemic of the H1N1 influenza virus. And all of a sudden, this caused people to get very, very sick, particularly young children with asthma. And oh, by the way, they're also at risk of having other allergies like egg allergy. So we just didn't know. And then since then, there's been over 30 published trials or guidelines that have all demonstrated the same thing. It's very safe to administer influenza vaccine to children with egg allergy, including those who have a history of anaphylaxis to egg. Since then, we also have different vaccines called flu block, which is a recombinant vaccine. There is no egg protein. It's also not a live virus. This is only indicated down to the age of 18 years, however, so this doesn't apply to young children. Next slide, please. This was studied, go ahead and hit one more time, and published in the Journal of Allergy and Clinical Immunology a few years ago. So this was about 56 patients with anaphylaxis to egg. They received over 115 injections, and they had no episodes of anaphylaxis. Only 3 of them developed localized irritation at the site of the injection, which probably wasn't even due to egg. It was probably just a common side effect that you can see if you administer flu vaccine to enough kids. So next slide, please. Definitively, it's been shown that it's very safe. There are recommendations that have come out. Go ahead and go all the way to the end. There's general agreement that there's overall safe and very you can give. So if you look at the allergists, so the Joint Council of Allergy, Asthma, and Immunology, egg allergy is not a contraindication regardless of the history. You can wait in the office any particular period of time. You don't have to refer to an allergy specialist. If you look at the Centers for Disease Control and the American Academy of Pediatrics, they say, well, if you have egg allergy, go ahead and give it, but watch for 30 minutes just to be on the safe side. And then if they have a history of anaphylaxis to egg, then they should be referred to an allergist. But they still say it's safe to administer, take certain precautions. So as an allergist, we're very happy to see all these patients. All we're going to basically do is administer the shot, and then they'll be fine. Next slide, please. Okay, myth number 3. You can't skin test children until they're 2, 3, 4, 5, X amount of ages. Next slide. So let's talk about skin testing. Go ahead and go all the way through. Thanks. So this has been around for almost 100 years. It's been widely used as the main way of testing for allergies in the office for the last 50 years or so. And what this does is you take a liquid amount of the allergen. You can do any allergen, whether it be inhalant allergens or food allergens, place it on the top layer of the skin, and then you prick through the top layer of the skin. If the person who's having the test applied has specific IgE antibody attached to the allergy cells, which are called mast cells, then it's going to basically cross-link them and open them up. Next slide, please. And then what happens is these mast cells or allergy cells will open up and they'll release a chemical called histamine. And histamine causes all the symptoms of allergic reaction, including hives. So within 15 minutes, they're going to get a hive at that spot. So they'll get a wheal, which is the bump, and the flare, which is the redness. Now, just like I talked about blood testing, the size of the test doesn't tell us how severely allergic you are. It can only help predict the likelihood that an allergy actually exists. So if you have a really big skin test, then yeah, it's more likely that you are allergic, but it doesn't tell us that you can have an anaphylactic reaction necessarily. Next slide. So at the top part of this, you see this wonderful little schematic about what these allergy cells may look like. So you have all these sort of preformed granules or little compartments that contain histamine. The green little Y-shaped structures are representative of IgE antibody. And when the IgE cross-link and they open up, you immediately release those chemicals. And then what you see is what you see on the bottom here. You get the big bumps. If you look at the number 7 there, you see the white part in the middle. That's actually the wheal or the bump, and then you get the redness around there. And what we measure, what's clinically relevant, is the size of the bump. But you have to compare the size of the bump to both a positive and negative control. So there are some people that just have very sensitive skin, and if you put salt water on their back, they're going to react to it. So we do a salt water negative control, and we actually use histamine as our positive control. So the bump has to be compared to both of those to help determine how relevant it may be. Next slide. This is actually studied. So in looking at skin test reactivity, this is a study from about 30 years ago. They actually took young infants down to the age of newborns and 3 to 6 months, 6 to 12 months, and adults as well. And they applied basically positive controls to the skin. So they looked at 2 different concentrations of histamine, which should cause, and then codeine. So codeine is a narcotic medication that's often used for pain control. As an aside, one of the reasons why a lot of people experience itching and or hives or what may look like an allergic reaction when they take narcotic medications isn't because they're truly allergic to those. It's because these are very good at causing release of histamine from those allergy cells. It's just a side effect of the medicine, which is also a reason why we actually can't skin test for allergy to them, because they're very irritating to the skin and they cause a positive control. So I don't want to go too far off tangent. Well, basically what they found was that they put a bunch of these tests on a bunch of different people of different ages, and they found that the skin test reactivity is extremely reliable in all ages, all the way down to 3 months of age, and it's still probably reliable even down to birth as well. We do see that the wheal size or the size of the bump may not be quite as large in very young, less than 3 months of age, or for people who are older than 50. But the skin test is extremely reliable at any age. Next slide. So I often like to say skin testing can be performed as soon as the shoulder is delivered. So obviously that's tongue-in-cheek a little bit, but there's no reason to delay skin testing to detect allergies. Next slide. So in conclusion, go ahead and all the way down. So this is really based entirely on myth. It's really reliable at any age, and it's an accurate way to assess for the presence of specific IgE. Go ahead and hit it one more time. There you go. Oh. Go ahead one more time.
Dave, there's nothing else on it. So
oh, okay.
we
That's
just
okay.
go to the next one.
Yeah, that's fine. So the other thing is, I often hear, here we go, thanks. So a lot of times the skin tests are negative. Now, let's think about why that is for a second. So a lot of times it's because somebody's being tested for IgE allergy when IgE allergy is not present. So a lot of young infants may have stuffy, runny noses, sneezing, things like that, but they're just not allergic to it. They have other reasons for having those symptoms, so the tests are negative. Or they are tested for symptoms that aren't consistent with an IgE-mediated food allergy, chronic constipation or reflux or things like that. So yeah, those tests are going to be negative in that case. So that may be extrapolated to say, oh, well, the testing's unreliable at that age, when in fact, it's not that testing's unreliable, it's just that what was being tested was not an allergic condition. And then a quote that I would like to say is, it's common sense. If you're old enough to have allergies, you're old enough to have a test that confirms you have allergies. It just makes sense. So hopefully, my explanation over the last few minutes clarifies some of that in regards to that myth. Next slide, please. Okay, myth number 4. Shellfish, iodine, and radiocontrast media, oh my. Next slide. This is one of my favorites just because it just fascinates me, the origins of this. So there was a great survey done a few years ago of over 200 physicians in 6 different major academic centers. They focused on radiologists and cardiologists, and the majority of these, 2/3 radiologists, almost all cardiologists, routinely ask patients about a history of shellfish allergy before they give them contrast media, which should be given for things like catheterization, CT scans, things along those lines. And then a third radiologist and half the cardiologist said, you know what, if you tell me you're allergic to shellfish, I'm not going to give you the contrast media. We're going to have to do another test. So it's fascinating. Next slide. But where does this come from? So I have been really intrigued by this for a while, and it took a while to find this out, but I dug up a report, and this is 1975, single author. What this author did was they basically did, it was a survey. They asked several hundred people, do you have a history of having any reaction to contrast media? If so, do you have other types of allergy? Well, those that had any allergy were twice as likely to have a reaction to contrast media, which is likely to be true. I'll talk about why in a second. Then they said, what are you allergic to? The number one allergy listed was seafood. 15% of people said I'm allergic to seafood. Oh, by the way, they also said I'm allergic to egg, milk, and chocolate. Now, never once in my career, I'm allergic to chocolate and I can't get radiocontrast media, but it's the same exact listing on there. All of this was by self-report, so there's no confirmatory testing that was ever performed. But what happened after this, next slide, is that this association became more prominent, but the origins are really unclear. It was likely created by physicians trying to explain what this single report found. And they said, aha, well, shellfish allergy equals reactions to contrast media. There's iodine in contrast media. There's iodine in shellfish. It must be due to the iodine. Well, there's one important fact that was sort of left out of this. Iodine is not an allergen. We all have it in our bodies. It's in table salt. Iodine is this very small molecule. It's literally too small to cross-link IgE antibodies. And oh, by the way, for people that actually have fish and shellfish allergies, they're not allergic to iodine. They're allergic to these muscle proteins present inside the fish and shellfish called tropomyosin and paralbumin, which has nothing to do with radiocontrast media at all. Next slide. So there are reactions that occur. It's about 5 to 12%. And if you do have allergies, you're more likely to have reactions to radiocontrast media. Not because you're allergic, it's because your allergy cells are very twitchy, and they will open up very easily. So if you put a high osmolar gradient, such as radiocontrast media, in the veins, it literally is going to suck the histamine out of the allergy cells, causing all the symptoms that will look like anaphylaxis. It's just not technically due to an allergic reaction. It looks the same, we treat it the same. But there's really no reason to be asked about seafood allergy. There's no connection whatsoever. Next slide. Okay, we're going to finish up with our last myth, and then we'll take some questions at the end. So myth number 5, epinephrine is dangerous. Next slide. So why do we worry about anaphylaxis? Well, recent reports have shown that about 2% of the population in the United States are at risk of having anaphylaxis. That's 1 in 50 people. We know that these risk factors have increased over the last several years. We know that food allergies have increased by over 50% in the past decade, and patients are ill-equipped to handle anaphylaxis. There's been a lot of reports, so I'll highlight a couple in a few minutes as well, but half of patients who go to the ER for anaphylaxis don't receive self-injectable epinephrine. So this is a real problem we need to worry about. Next slide. Fortunately, deaths are rare. There's about 150 deaths per year in the United States due to food allergy and 100 deaths due to other causes of anaphylaxis. The vast majority of those are actually in the hospital setting. But quality of life suffers. So if you're at risk for having anaphylaxis, which I'm going to guess the vast majority of our listening audience is very familiar with, this can lower your quality of life. You have to worry literally every time you're going to make a food choice, whether it be snacks or meals, whether what you're going to consume is going to be safe or if it's going to cause a more severe reaction. And interestingly enough, some recent data regarding quality of life show that those with milk and egg allergy actually have lower quality of life compared to those with peanut and tree nut allergy. And the speculation is that these are just much more difficult to avoid because they're a staple of our diets, and it can lead to challenges finding safe alternatives. Now, what are the causes of anaphylaxis? Not just food allergies, although that's one of the more common causes, but people can have venom hypersensitivity from yellow jackets, honeybees, wasps, hornets, things like that. Medications can cause anaphylaxis. Latex allergy as well, which thankfully we're not seeing nearly as much as we used to, as most hospitals are latex-free, but it still occurs. You can have idiopathic or unknown causes of anaphylaxis, which are extremely scary scenarios, both especially for the patient, but for myself as well when I see these patients. So I can't tell you exactly what's causing your anaphylaxis, but you keep experiencing it, so it's really hard to avoid what may be causing it. And then there's exercise-induced anaphylaxis, which is a very rare trigger as well. Next slide. So what is anaphylaxis? Well, part of the problem is that there really wasn't a universal agreement or definition until the last decade or so. And in the mid-2000s, the National Institute of Health and various food allergy societies said we need to have a worldwide symposium with the world's experts and let's get together. And they got together and had this great symposium, and they came up with basically anaphylaxis is a serious allergic reaction that is rapid in onset and may cause death. Well, hey, thanks a lot. Well, there's more to it, which I'll show you, but that's basically the overarching theme here. And then they actually developed criteria to help patients, lay personnel, emergency medical responders, and physicians as well. Next slide. So from this report, go ahead and go all the way through. You can see there's 3 different criteria. So the first criteria, this is going to be acute onset, rapid progression. This isn't something that happens over, hours or days. This is going to happen very rapidly. And really, by definition, anaphylaxis is more than one organ system. So skin symptoms occur almost all the time. But the absence of skin symptoms, which would include hives or swelling or rash or flushing, doesn't mean you're not having anaphylaxis. And these criteria are going to be almost all the one. So if you look at the right, pruritus is itching, flushing, hives, or swelling, and you can have difficulty breathing, shortness of breath, or you can have low blood pressure, things like that. So any combination of those would be anaphylaxis. Next slide. Oh, next slide, please, Mel. We may be hung up here. We can go. Thanks. Looks like we're stuck. We'll go back to the last one. So the second criteria, thank you. So this one is if you know you have an allergy and you're known to have exposure, then you start thinking more GI symptoms. So this is somebody basically in the food allergy world. So you know you're allergic to peanuts. You accidentally eat something that has peanuts, then you're much more likely going to have GI symptoms such as vomiting, abdominal pain, diarrhea. In addition, you can have all the other symptoms as well. And then next slide, please. And then the last criteria, this is extremely rare, but you can have isolated low blood pressure if you have a known allergy and known exposure to your allergen. Bottom line, this is going to be almost always somebody receiving allergen immunotherapy or an allergy shot in the office setting, and you can just drop your blood pressure as a sign of your systemic reaction. So it would be exceptionally unusual for somebody out at home, school, to have this as their only symptom of anaphylaxis. But these are the criteria that were developed. And then they were actually studied and validated and standardized and distributed to physicians and things like that. Okay, go ahead and go. Well, actually, don't go through yet. So in regards to fatal anaphylaxis, you already heard me mention that it is rare, thankfully, but it does occur. In adults, medications are the most common trigger, whereas in children, it's almost always going to be a food allergen that's the cause of it. And then the risk factors would include, go ahead with the first one. The first one is delayed administration of epinephrine. So people who don't have epinephrine with them at the time of their reaction, or if they don't have it administered, by as little as 5 minutes after the start of symptoms, are at risk for having fatal anaphylaxis. Next one. People who have asthma are more likely to have more severe allergic reactions because their airways are much more twitchy. They're more likely to have bronchospasm, difficulty breathing associated with all their other symptoms. Next one. Teenagers are at risk for having fatal anaphylaxis. Teenagers generally partake in a lot of risk-taking behaviors at their age, including not carrying epinephrine with them, not telling food handlers about their food allergies, giving in peer pressure, not willing to speak up regarding their food allergy because they don't want to feel different, and things along those lines. So we know that that's a risk factor for really severe outcomes as well. And then last one, and if you have a history of peanut, tree nut, or shellfish allergy, these allergens are really good at causing more severe reactions. But anaphylaxis absolutely can occur with any food allergy. So I don't want you to think that if you just have milk allergy that you're not at risk, because it certainly can occur. Next slide, please. So anaphylaxis is a severe, sudden onset, rapidly progressive symptoms involving 2 or more organ systems: skin and breathing, skin and GI, GI and breathing. Upper respiratory congestion, runny nose, that counts as one as well. That's your upper respiratory tract. If you have a food allergy, it almost always requires ingestion of the food allergen to cause severe anaphylactic reaction. Reactions can occur through casual contact or through inhalation, but generally not going to cause the 2 or more organ system. The only acceptable treatment for anaphylaxis is epinephrine. If symptoms persist or return, you must give epinephrine again. If you're not sure what to do, give epinephrine. If you think about giving epinephrine, give epinephrine. This is a life-saving medication. You must call 911 and be taken to the nearest emergency department for observation. This isn't because epinephrine is dangerous. It's because about 20% of people will have a biphasic reaction. So symptoms may go away, but they may come back again in 1 hour, 2 hours, 3 hours, 4 hours. In very rare circumstances, they can come back even 12 hours later, a day later. That's extremely rare. So it's strongly recommended that you be transported to the nearest emergency room for monitoring and observation for the next 4 to 6 hours. I know it's inconvenient and something that you certainly don't want to do if you don't have to, but it's important because monitoring is very, very crucial here. Next slide. Now, in regards to epinephrine, they come in preloaded auto-injectors. The side effects are minimal when they're administered through the muscle at the recommended doses. And actually, the cutoffs will be a little bit lower. So 25 kilograms is where a lot of people would start doing the regular adult strength. But for children, you can go to 0.15 milligrams, and then it's weight-based. After you're above roughly 60 pounds or so, then you go to 0.3 milligrams. You already heard me mention the majority of deaths from anaphylaxis are associated with delayed or lack of epinephrine administration. Antihistamines, you haven't heard me even mention it until now. They're second-line therapy. Benadryl is not a treatment of anaphylaxis. After epinephrine is given, if you want to give it in addition to it, that's fine. Steroids, prednisone, do not help anaphylaxis. It takes several hours before the mechanism of steroids go into effect in the body to actually reverse inflammation and all the symptoms. You cannot rely on this. And then supportive care as well. Lie down, make sure that the airway is protected, things along those lines. Next slide. These are the examples of the currently available epinephrine auto-injectors. I'm sure most of the people in the audience are very familiar with these devices. I'd say that the two that you're going to see most prominently available will be the Auto-Q and the EpiPen. The Adrenaclick is available in some pharmacies as well. Next slide. Now, we know that patients don't always know best when it comes to anaphylaxis. A lot of times they feel epinephrine is harmful and maybe dangerous. If you think about it, epinephrine is really adrenaline, and we all have adrenaline in our bodies. It's the fight or flight response. If you're being chased by a bear, that's your adrenaline that kicks in that helps you run away. That's exactly what this does. So if you actually give epinephrine to the wrong person, or for somebody not having anaphylaxis, they're going to get a little jittery. Their heart rate's going to go up. They might get a little sweaty, but that's it. It's not going to cause their heart to stop or anything like that. So the side effects are not that worrisome. However, you want to be very careful. Make sure you don't inject it into your fingers or thumbs or things like that, because then it's very constrict and cause more problems. A lot of people don't understand that epinephrine treats all the symptoms of anaphylaxis. So hives, swelling, difficulty breathing due to squeezing of the airways, nausea, vomiting, low blood pressure from dilated blood vessels. Epinephrine treats all of those symptoms. By the way, epinephrine is a great treatment for asthma as well. We use it all the time in the hospital setting when other conventional treatments aren't working. I'm not saying you should use your EpiPen next time you're having an asthma attack, but you know what? If you're in a pinch, and especially if you don't have your inhaler with you, absolutely, it's going to help open up your airways. The majority of people actually can't demonstrate proper use of self-injectable epinephrine, with 84% misusing it during demonstration. And in a study actually we conducted a couple of years ago, we found that less than 60% actually had epinephrine with them at all times, including those with a history of anaphylaxis or peanut allergy, those at highest risk. Next slide. But it's not just patients, it's also physicians. So there's been a lot of recent literature, including our own that I showed you earlier, that really highlights poor physician understanding. So symptoms of anaphylaxis, up to a quarter didn't recognize that breathing problems can occur. A third didn't recognize that peanut was a cause of anaphylaxis. And then in the emergency room, only 2/3 actually used the intramuscular route. So a lot of times we'll give it intravenously, which then significantly increases side effects and concerns for problems from epinephrine. So we should be using these epinephrine auto-injectors in the emergency setting as well. Next slide. So really, in conclusion, misperceptions about food allergies are common among patients and physicians alike. These are just rampant, and there's a lot of work that needs to be done. There's a steep learning curve. So if you're hearing something from somebody, a well-intentioned friend or family member, or something you're reading on the internet or Facebook, and it just sounds wrong or too good to be true, unfortunately, it probably is. When in doubt, make sure you discuss with your allergist, because they can hopefully give you the latest and greatest in regards to what the evidence supports or refutes. Next slide, please. And I'd like to thank everybody for tuning in today. I know it's the middle of the day and a lot of people have things to do, or for those who are listening later. I truly hope that this was helpful for you. There are, as I mentioned before, I could spend hours talking about this, and we'll see how it goes. If there's demand, and I'm happy to come back and address other misconceptions and myths as well. But at the end of the day, make sure that the source that you're getting your information from is reputable and that it can be backed up by evidence. Try to avoid anecdotes and stick with what the evidence and science backs. So thank you. All right, I think I'm going to turn it back over to Linda, and then we have some questions.
Okay, thanks, Dr. Dave. As always, you jam-pack a lot of information into a itty-bitty living space, and it's really so helpful to us to learn all about this. Before we get started on the questions that have been submitted, there was a few that came in, and I know that you addressed them, but maybe you need to reiterate something. So with regard to false negatives, what does it mean in terms of the chances of having anaphylaxis if the skin and blood tests are negative for food?
Yeah, so no test is 100%, but the negative predictive value for both skin and blood tests is generally about 99%. So they're really, really good. That being said, if your history is one of anaphylaxis, so if you come in saying, I ate this and I had a severe life-threatening reaction, and follow-up testing is negative for both skin and blood, then there's always the third option, which we didn't have time to discuss today, and that's an oral food challenge. So that's where the oral food challenge in the office setting can be very helpful, where you can be given very small, gradually increasing amounts of the food that you are suspected to be allergic to under physician supervision. And then if you tolerate that entire challenge without any problems, then you're not allergic to it, you're not at risk for anaphylaxis. But if you start to have symptoms, you're in a proper medical setting where you can be treated promptly, and we go very, very slowly, so hopefully wouldn't go from 0 to 60, but you actually have some time to make sure that things are going well. So there's always that option as well. But as a general rule, if you don't have a history of having any allergy or anaphylaxis and you have negative tests, you're good to go. You're not detecting any IgE. You're not at elevated risk of having anaphylaxis. So negative tests are generally reassuring.
Okay, and then to reiterate again, allergy blood and skin tests are only about 50% accurate?
Yeah, it depends on exactly what food or what test you're looking at, but we get about 50% false positive results. And if you think about, especially so now that you have maybe a better understanding of how we interpret the tests, so you get these little bumps on skin tests. How do you interpret that? Is that positive, negative? Do you measure the size of it? And then on blood tests, if your number comes back at 0.81, what does that mean in the grand scheme of things? So that's really where this false elevated and 50% reliable thing comes from, because you need to interpret it in the proper context. You can't just look at a test by itself in a vacuum and know exactly what it means.
Okay, terrific. And then did you address the nasal flu vaccine and egg allergy?
No, I did not. Do we have the question slides? Yes, there we go. Okay. So we have the nasal spray form of the flu vaccine. It was actually recommended for young children. It seems to be a little more effective. It's a live virus, so if you have poorly controlled or more severe asthma, you can't receive it. There are no recommendations right now that this is safe to give for people with egg allergy. However, in the last year, there have been two rather large studies that have both shown that this is very safe to give to people with egg allergy. So I cannot tell you that it's entirely safe. I can tell you that we're accumulating evidence, just like we did with the influenza injection, and that I would anticipate that sometime in the next year or two that recommendations will change that would allow us to administer this to egg allergic people as well. But we're not just there yet.
Okay, terrific. Okay, might as well just move on to the other questions that we already have on the slide. So if someone's allergic to peanuts, a type of legume, do they have to avoid other legumes like peas and beans? And what about seeds like sesame?
Yeah, so this is a great question. There's no easy answer to this other than to say, the vast majority of people with peanut allergy are not allergic to other legumes. It certainly is possible. There can be some cross-reactivity. If you look at testing by itself, a lot of times you're going to see some mild elevation in the skin prick or blood test to other legumes if you have peanut allergy. Doesn't mean you're necessarily allergic to it, but when you do these tests, they kind of look similar because they're both legumes, so you may get these little falsely elevated results. Same thing happens for people with tree pollen allergy to things like birch tree. Oftentimes you'll get a falsely elevated peanut test by skin prick or by blood testing, because there's a lot of cross-reactivity between peanut and birch tree. Now, obviously, the best test is what happens when you eat the peanut, so if you're eating peanut and you have the test, you're fine. There is no cross-reactivity between peanuts and things like seeds and tree nuts. However, if you have a peanut allergy, you're likely an allergic person. You are an allergic person by definition, and these are also other common causes of food allergy. So while there's no cross-reactivity between the two, it is, there's about 10% or so that have allergies to both. But the vast majority of people who are allergic to peanuts are not allergic to tree nuts, and vice versa. However, it definitely warrants discussion with your allergist to determine what your best approach is for you and your child.
Okay, great. Next question. My son tests positive to wheat. I'm worrying about internal damage to his GI tract. Should he be tested for celiac disease?
Yeah, so celiac disease is a condition that has nothing to do with IgE allergy or allergic reactions. This is actually an autoimmune condition where the body forms an IgA antibody against its own cells in the intestine, which basically attacks the body whenever you consume gluten or wheat. The treatment is actually removing gluten from the diet, and the body tends to heal itself, and people do rather well. But this is very different than having a wheat allergy. So if you have an IgE test towards wheat by skin prick or blood test, this has absolutely nothing to do with celiac whatsoever. So they're just completely separate conditions, but there's often a lot of confusion given the obvious overlap between the two.
Okay. Next question. Can you talk about the new tests for food allergy, and are they more reliable?
Yeah, so this is something, nothing's ready for prime time just yet. The closest thing is we have these component diagnostic tests. So you can actually take the different food allergens, such as peanuts, and break it down into the different specific proteins that may cause an allergic reaction. So in the example of peanuts, Arachis is the allergen, so the abbreviation would be ARA, and then H. Then you have ARH1, 2, 3, 6, 7, 8, 9, so on and so forth. This test can help show exactly what type of allergen your body is responding to. And we know that ARA-H1, 2, and 3 are more likely going to cause an anaphylactic reaction. So if you do a test like that, and all of your testing is positive or elevated towards 1, 2, and 3, then yes, you're more likely going to have an anaphylactic or allergic reaction. However, if you do that test and 1, 2, and 3 are negative or undetectable, and everything is shifted towards things like ARA-H6, then that's more consistent with being cross-sensitized to birch tree pollen that I talked about a few minutes ago. So these are being used more and more. They're being studied in different populations, and the results are they don't necessarily apply across the board. So, for instance, people in Europe seem to have a different allergic profile compared to those in the United States. So you can't just take it across the board and sort of apply it to everybody. And if you already have a known history of anaphylaxis to peanut, there's probably no reason to do a component diagnostic test anyways, because you already know that you have a severe allergic reaction. This is really best indicated for those that probably were tested inappropriately without ever having eaten peanuts, and they weren't sure if they're actually going to have a reaction when they consume it. And then there's also some experimental testing that's showing some promise, looking at another allergy cell in the bloodstream called basophils, and you can sort of combine the basophils with the different allergens, and you can measure levels of chemicals that are released from them to help indicate both the likelihood that you're allergic and also the severity potentially. These aren't available commercially right now. They're still being validated and tested in different populations and trying to determine sort of cutoff levels and interpretation values for them. So there's some stuff coming down the pike, but as of this moment, it's really going to be skin prick testing and serum IgE testing.
Great. Maybe one more question. It's 1:55.
Sure.
People talk about the levels of allergy based on blood test numbers. What does this mean? And if there's false positives, how can you be sure an allergy truly exists?
Okay, so let's talk about the first one. So yes, so we know that with many food allergies, especially in young children and infants, they tend to go away as kids get older. Especially milk, egg, wheat, and soy. Unfortunately, only about 10 to 20% of kids with tree nut, peanut, and seafood allergy outgrow as they get older. But we can actually measure those levels in the blood, as I went through before, and compare them over time. So generally, it happens about once a year, and we'll look at numbers over time, and if they trend downward, then that would be consistent with somebody developing tolerance or losing their allergy. And then once they reach a certain, sort of safe level, similar to those cutoff levels I showed you before, then you can consider an in-office oral challenge to see if they can actually tolerate it. So the numbers can be very helpful to follow over time. As a general rule, personally, I will do skin prick testing at the initial visit to help establish the diagnosis, and then I'll follow the blood testing over time for comparison levels. Many people will have skin tests that stay elevated or positive, even though their allergy may be going away. So it can be extremely helpful to look at the blood and see what those numbers are doing over time. So when it says improving, it means that you're getting to the point where you may have outgrown your allergy, if that makes sense. Now, the second question, because of false positives, how can you be sure an allergy truly exists? So this goes to the history. So you really shouldn't perform allergy testing for foods unless you have a history that's suggestive of an allergic reaction to that food. And what I mentioned before, an immediate onset IgE reaction to that food, hives, swelling, difficulty breathing, anaphylaxis, things like that. So you really have to interpret it in the appropriate context. You could say, I'm scared to give my child anything because I have no idea if they're going to react, and I want to have all this testing done. Well, testing doesn't predict future reactions at all. testing can only confirm prior reactions. And there's really no indication to withhold foods unless, one is if you have other food allergies, it may be helpful to evaluate for the highly allergenic foods. Or if there's a strong family history, especially in siblings, of particularly peanut allergy. It's controversial, but many of us will actually test the infants before you introduce it. But we do know that withholding it doesn't prevent the onset of allergy. So yeah, you just really have to take the history into context.
Okay, I have one. We're going to have to wrap up because we're getting close to 2 o'clock. But I have one last question, and that is, could you describe or explain about whether every reaction is going to be worse than the reactions prior in terms of patient history? We've been getting a lot of questions regarding, will my next reaction be anaphylaxis or will it be mild? And I thought maybe you could speak to that.
Yeah, that's a great question. I hear it all the time. So reactions can progress over time. So if your first reaction is hives, it can be anaphylaxis the next time. As a general rule, reactions tend to stay the same and reproduce themselves, but I don't want to give anybody the false sense of complacency because they can progress, absolutely. And then if your first reaction or subsequent reaction is that of anaphylaxis, you should assume that you're going to have anaphylaxis every time that you eat that food. That's just what your body does for reasons that we don't fully understand why some do and some don't. So yeah, that's why we preach strict avoidance of the food allergen and always having epinephrine immediately available just in case you have accidental ingestion, because you truly never know. Now over time things may get better and better, especially if you're outgrowing an allergy, but as long as you're considered to be allergic to that food, you need to assume that your reaction could be more severe or be anaphylaxis next time you eat it.
Thank you very, very much. Lots and lots of information crammed into 1 hour, and I was noticing that some folks were asking a question you've already answered, so I would encourage those of you who arrived late or those of you who maybe didn't catch everything to watch the recording. We'll be sending you a link in a few days, and you'll be able to look at the slides again via the video and be able to take notes at your convenience. So with that, I'm just going to say thank you very, very much, Dr. Dave. I'm going to move on to the giveaways and then wrap up and close, but I really sincerely appreciate your time and your being here with us today.
Thank you, Linda. Thank you, everybody who tuned in and listens at any point. This really, it's a lot of fun for me, and I hope it was very helpful for everyone. Thank you.
I think so, yeah. So the giveaways, we have 2 gifts from Hope Page Medical ID Marketplace, and those will go to Kira McCoy and Mona G. And then we have Libre Against Naturals. We're going to be giving you a iodine video and then a gift card from Libre Naturals for their online store. And the winners of those are Ronald, S-U-N-O-G, Sunog, and Tracy Steffel. So congratulations to all 4 of you. We will be in touch to make arrangements to get these shipped to you. So we're going to go ahead and tell you once again that an archive of this webinar will be available next week sometime. We'll send out a follow-up email to all of you with the link to the archive and also a list of additional resources that we will be putting into the blog post. And then finally, with closing with a few comments here, Cutoff Allergies is part of the Asthma and Allergy Foundation of America, the nation's oldest and largest asthma and allergy charity. If you found today's session valuable and would like to see that we continue this webinar, please keep donations to KSA and AFA in your end-of-the-year giving plans. On the screen before we go is our peel pumpkin information. Be sure to visit our website for a couple of blog posts that we've done with free downloads and then craft ideas that you can use to make teal pumpkins for your home or for school, and to use the Keep It Teal hashtag in your social media posting. So let's keep it teal and try to encourage non-food treats. And then lastly, our next webinar is going to be in November with social worker Sloan Miller, and she's going to be talking about getting food allergy confidence for the holidays. I know this is always a challenging time for us, and so she's going to give us some personal experience and tips on how to navigate these sticky situations that we run into at home, at school, with family gatherings and all that kind of stuff. So once again, thank you for joining us, and I'm going to sign off for now and hope to see you next time. Bye.